Good morning, everyone. Myself, Dr. Pankaj, and welcome you all in Pedia Academy by Dr. Pankaj. So, we are continuing our amazing series of INISS uh, Neonatology, which is actually divided into different sections. We have discussed many topics earlier also. So, now we will discuss today neonatal hematology. Neonatal hematology is very important in neonatology as per se because it deals with many multifactorial system disease. Okay, exam point of view, it is ultra important. So again, my humble request from you all is give you 100% attention because this is vital to exam. And we'll start without further delay. Uh, Till you like, share and subscribe our channel. So here we are with neonatal hematology today. So yes, uh, in neonatal hematology, first thing first, this is actually changing site of hematopoiesis during human gestation. It is very important. So just be with me. At 3 weeks of gestation, circulation is established. Important question. Okay. Then 23 to 40 days AGM erythropoiesis. This is orotogonodomesonephron. So AGM. I think this is PYQ question. Okay. At 23 to 40 days AGM erythropoiesis started. 8 to 9 week of gestation in circulation platelet appears. Okay, these timelines are ultra important. They are usually asked. Okay, 2 to 3 week yolk sac comes into play, and 4 week of gestation liver, and liver goes on producing the cells of hematopoietic system. At 11 to 12 weeks bone marrow start taking over, but one PYQ also at 5 to 6 months of gestation, liver has peak erythropoiesis. Okay, then 30 week of gestation, bone marrow is major site of hematopoiesis. So this flow chart or this diagram is important. Just keep revising it. Going forward, approach to bleeding neonate. Okay, so this topic is itself is very important. We have to look through coagulation profile of a newborn, which is different from child or adulthood. Okay, so in newborn what happens, platelets are generally hyporeactive. Okay, coagulation factors, vitamin K dependent factors are generally low, that are 2, 7, 9, 10 are low, along with factor 11, factor 12 also decreased by 50%. The cumulative effect of both of these are increased PT and APTT level versus von Willebrand factor is increased in newborn, hematocrit is increased in newborn, and natural anticoagulants are increased. So overall coagulation profile of newborn is balanced in spite of having all these changes. So you have to remember all coagulation profile in newborn ultra important. On the other level, if we discuss what are the protein levels which are elevated as compared to adult in newborn. So further dissecting it, we have discussed uh, in this discussion also fibrinogen factor 5, factor 8 and von Willebrand factor. These are increased. So they can ask which factors are increased in newborn. You have to answer that. Alpha 2 macroglobulin is increased, very much important. Tissue plasminogen activator is increased, plasminogen activator inhibitor is increased. So they can ask all except question fibrinogen factor 5, factor 8, von Willebrand factor, alpha 2 macroglobulin, tissue plasminogen activator and plasminogen activator inhibitor. These are increased. Which proteins are decreased in actually coagulation anticoagulation profile? So as we discussed, these factor 2, 7, 9, 10 along with 11, 13, 12 are decreased. Okay, precalorin is decreased, high molecular weight kinogen is decreased, antithrombin third, heparin cofactor second, protein C and S all are decreased. Plasminogen and alpha 2 antiplasmin is increased. So this table you can expect one or two question out of it, because this is so vital is hemostasis or coagulation profile of newborn depends on these factors. Okay, so going forward, how you will approach a bleeding neonate. Okay, this is simple flow chart, just stay with me. Okay, if a neonate is bleeding, so if defect in platelets is there, okay, so defects in platelet can be two type, either platelets are decreased or their morphology is disturbed. So quantitative defect means platelet number is decreased. Qualitative defect means platelet functioning morphology is different. First see qualitative defect seen in drug in like Bernard-Solis syndrome, Galen-Mann thrombocythemia. So these two syndromes are qualitative defects in platelets. But when we talk about quantitative defect, it can be early onset thrombocytopenia or late onset thrombocytopenia. Cutoff here is 72 hours. Just remember, this is also previous year NEET SS question. Okay. So what are the early onset thrombocytopenia or qualitative defect in platelets are perinatal asphyxia, intrauterine infection, autoimmune diseases, and alloimmune diseases. Okay, so alloimmune thrombocytopenia, that is NET, autoimmune thrombocytopenia, infection, perinatal asphyxia falls into early onset thrombocytopenia. If we talk about late onset, sepsis, NEC, infection also, and amegakaryocytic thrombocytopenia also falls in this category. Okay, so now in this extreme right side of this flow chart, vessel wall disorders can also lead to bleeding, that is hemangioma, vascular malformation, and trauma. Combined effect, like all these combination effect can leads to DIC, ECMO, hepatic dysfunction, and sepsis. Defect in coagulation, we have discussed platelets, vessel walls, and we have to see defects in coagulation. So there may be inherited coagulation disorders and acquired coagulation disorders. Hemophilia, von Willebrand disease, dysfibrinogenemia, and acquired like vitamin K deficiency bleeding, drugs, and transplant placental exposure of drugs. So this is actually a very basic description of how a bleeding unit can be classified according to symptomatology or platelet coagulation combined vessel wall disorder. We'll discuss them in detail. Just remember how they are classified. Okay, so yeah, going forward to app test. Okay, so what app test is used for? It is the test that is differentiate maternal blood from fetal blood. Why it is required? If fetus is vomiting, bloody vomiting is there, or passing blood stool, so it is very important to differentiate them, because blood in stool in unit can be a indicator of NEC, but if it is maternal blood, we have to differentiate. So app test steps are previously asked twice or thrice. So what, just pay your attention here. What you have to do, one part of stool and vomit you have to take along with 5 part of sterile water. This is 5 part. Okay, centrifuge it for 2 minutes. You have to centrifuge them for 2 minutes. Then you have to clear pink supernatant, that is actually this take it of 4 ml of this, add 1 ml of 0.25% 10% NaOH 1% NaOH, sorry, and if HbA is there, that is adult hemoglobin is there in blood, it will turn from pink to yellow brown. That will define that it is maternal blood. If the blood is of fetal origin, that will contain hemoglobin F, it will stay pink and fetal blood is confirmed. So if it doesn't change color, it is fetal hemoglobin. If it changes color from pink to yellow, it is maternal blood. So just revise the steps of app test, it is important. Going forward, okay. interpretation of coagulation test. I'm not going to wholehearted hematology. You can see my hematology lectures at Nelson based hematology lectures. Now we'll discuss in brief how we interpret coagulation tests. Okay, if PT is increased, okay, so you have to assess the factors of 7 vitamin K deficiency, that is mild, and warfarin deficiency. Okay, so in these three condition factors, 7 deficiency, warfarin deficiency, and early onset vitamin K or mild deficiency of vitamin K leading to PT increasement. APTT is increased, so factor 8, 9, 11, all we are familiar. Severe wall Wilburn disease, dysfibrinogenemia, and heparin contamination. Okay, so you have to remember warfarin leading to increased PT and heparin contamination leading to increased APTT. What if both PT and APTT are increased? These are increased in many conditions. Important are DIC, liver disease, vitamin K deficiency, that is severe, afibrinogenemia and dysfibrinogenemia. So this is important. So vitamin K deficiency mild leads to only prolonged PT, but when vitamin K deficiency is severe, it leads to prolonged PT and APTT. This is very much important. Okay, so here is a neonatal reference range of normal coagulation test. Just remember full term. Okay, just remember one value. If you can remember whole list, it is up to you. But just remember full term values. In full term, PT is 10.1 to 15.9 seconds. APTT is 31.3 to 44.5, and fibrinogen is 167 to 399 milligram per deciliter. These values are important for exam along with your practice also, because when you get a report, you just can see if this is full term neonatal PT value is this, so this is decrease, increase, or whatsoever. Okay, so now we will dissect bleeding neonate in detail. Okay, according to coagulation profile and well baby, sick baby approach. Okay, so a neonate is bleeding. You obviously you have to take history. You have to do physical examination, and you have to do coagulation profile that include your platelet count, PT, APTT, and other baseline investigation. You are done with examination, history. Now just stay focused. Okay, just see your baby is well looking or sick looking. The differential diagnosis of bleeding neonate will drastically change if the baby is well or sick. Okay, we will discuss the left side limb of this flow chart. If your baby is well, well, just see platelet count are normal in this first. Just see, okay, platelet counts are normal, PT is normal, APTT is normal, everything is normal. Baby is well, but baby is having bleeding. What are the causes? Just think. It may be any local cause and trauma. Okay, and qualitative platelet defects can be present like this. Two things are there, two differentials, any local trauma or qualitative defects of platelet like Bernard Soler or Gallagher thrombocytopenia. Okay, so this is very important. Going forward, I am going very slow in this flow chart because this is crux of coagulation disorders. Your platelet is normal, your APTT is also normal, but PT is increased. Isolated PT in well newborn indicative of factor 7 deficiency. Very much important. This is showing factor 7 deficiency. Okay, well baby, platelets are normal, PT is normal. Isolated APTT enlargement increasement in well baby suggestive of factor deficiency 8, 9, 11, and severe von Willebrand disease. Important. Again, next scenario. This scenario can be asked independently also as a question. Just understand the basic concept or basic theory behind it. You can be able to answer any question of combination of from this table. Many like 20 questions are possible from this simple looking table. or flow chart. Okay, next, well baby is there, platelet are normal, but both PT and APTT are increased. What you will think? You will think of vitamin K deficiency bleeding, important. Next scenario, your baby is well and platelet counts are low. Other thing are normal, like PT is normal, APTT is normal. What you will think? You will think of immune thrombocytopenia, very important. On the right side of limb, what we will see, sick baby is there. Your baby is sick. Okay, is uh, visible from outside and examination suggests your baby is sick. Okay, the similar scenario, platelet count are normal, PT normal, everything is normal, but just remember your baby is sick. What you have to think of, altered vascular integrity like prematurity, hypoxia, acidosis. You will not think of local cause trauma here because your baby is sick. So altered vascular permeability factors you will see. Okay, next case scenario. Your baby is sick. In this condition, platelets are normal. PT and APTT both are increased. So what you will see, liver disease and severe vitamin K bleeding disorders can do this. Okay, so you have to stay attentive. Your baby is sick, platelet counts are low, other things are normal like PT is normal, APTT is normal. What you will think? You will think of sepsis, NEC and renal vein thrombosis. This renal vein thrombosis was asked. One of the question was framed like that. You just remember, in this scenario sepsis, NEC and RVT will be the answer. Next scenario, platelet count is low, PT is increased, APTT is increased. What will be your diagnosis? DIC. Okay, so this is basic description of how you will classify a bleeding neonate and reach a diagnosis and do investigation management later. So you have to remember this. Okay, so laboratory diagnostic criteria of bleeding newborn, we have just discussed this in like previous slide. One thing I want to actually highlight here is this. In DIC and liver disease, in both PT is increased, okay, APTT is increased, platelets are low, fibrinogen is low. How you will differentiate? Previous year INI SS question. To differentiate between DIC and liver disease, a factor 8 value should be obtained. Factor 8 value will be normal in infant with liver disease and low with infant with DIC. So factor 8 is low and factor 8 is normal. So this question was asked. Other thing we have discussed earlier also. Okay. Many prothrombotic disorders are there which leads to neonatal thromboembolism. You have to remember just few which I have highlighted. Okay, the most common prothrombotic disorder, what is most common? That is factor 5 laden mutation. It is most common. Another are factor second mutation. Okay, if you can remember gene, well and good. Otherwise, it is not required. Other gene is that is MTHFR C677T gene mutations also leads to prothrombotic disorders. Okay, another gene is PAI14G 5G mutation. So you can remember 4G 5G mobile spectrum also if you want to remember as a mnemonics. Okay, antiphospholipid antibody syndrome, all we know it is cause of prothrombotic disorders. Chromosome 2q and chromosome 2q13 deletion is very important. These can lead to prothrombotic state of a newborn. Okay, so this is actually exhaustive discussion. Again, I want your 100% attention here because neonatal hematology is like mathematics. If you pay attention, it is linked everywhere and it is physiology which is actually very calculative. Okay, so coming back to our topic, classification of neonatal thrombocytopenia. As we discussed also, early onset, the definition should be less than 72 hours and late onset more than 72 hours. Okay, so chronic fetal hypoxemia, IGR, SGA is generally cause of early onset thrombocytopenia. in a well-looking baby? This was also previous year question. Congenital viral parasitic infection, birth asphyxia, renal vein thrombosis we have discussed earlier also. Congenital thrombocytopenia syndromes are many like TAR syndrome, which called Eldridge syndrome, and congenital leukemia is also cause of early onset thrombocytopenia. So you have to keep them in mind. Late onset thrombocytopenia we have discussed NEC, viral infection, thrombosis, and drug-induced thrombocytopenia. Some diseases can present with early and late onset thrombocytopenia both. These are sepsis, inborn error of metabolism, Kasabach-Merritt syndrome. Okay, so going forward, how you will approach early onset thrombocytopenia? We'll not discuss this whole flow chart. Just stay with me. Okay, if your child newborn is having early onset thrombocytopenia and platelet counts are above 50,000, so what you have to see, if baby is well, so it may be due to placental insufficiency. Just monitor the child, nothing else. But your platelets are above 50 but no evidence of placental insufficiency, just evaluate for sepsis and DIC. So this part of flow chart is completed here. Okay, I am dissecting this flowchart into very simplified explanation. See platelets if less than 50,000, see if baby placent insufficiency is there or not, and if they are, just monitor. If it is not, just monitor for sepsis and DIC. That's it. But his platelet count is less than 50,000. So what you have to see? You have to see sepsis, DIC, and neonatal alloimmune thrombocytopenia. You have to differentiate them. Don't go beyond this point because it is just actually how you will differentiate, but you will think of these factors. This was simplified approach of early onset thrombocytopenia. Similarly, late onset thrombocytopenia has approach as similar. You have to evaluate for bacterial, fungal, or sepsis or NEC. If any NEC or sepsis evidence are there, just treat them. If no evidence of NEC sepsis is there, evaluate for DIC, viral infection, thrombosis, drugs, Fanconi anemia, inborn error of metabolism. Going forwards, threshold of platelet count of neonatal platelet transfusion. When you will transfuse platelet in neonate, this is very important. If platelet count is less than 25,000, okay, in this condition, if neonate is not bleeding, even not bleeding, just transfuse platelets. Okay, important. Okay, it is very important. If platelets are less than 50,000 in this condition, or platelets are less than 1 lakh. Okay, if platelets are less than 50,000 or more than 25,000, means 25,000 to 50,000. In this condition, neonate with bleeding, current coagulopathy before surgery, and NET if previously affected sibling with ICH. These are only 4 criteria for transfusion of a platelet in this platelet range. But if platelet are less than 1 lakh, 50 to 1 lakh, you have to transfuse. If any major bleeding like IVH is there, major surgery is there, and net with ICH. So you have to remember these neonatal platelet transfusion criteria, very much important. Okay, so I'll discuss two important immune thrombocytopenia means any condition leading to immunity leading to thrombocytopenia. We will classify them into alloimmune thrombocytopenia and autoimmune thrombocytopenia. Alloimmune thrombocytopenia is neonatal alloimmune thrombocytopenia. Short form is NEIT, and autoimmune thrombocytopenia. Okay, this is actually slight complicated. We will remember this. Alloimmune thrombocytopenia. Just remember, a lady is there, and she is actually in fight with her husband. So her child came, and uh, maternal her child is having antibodies or something like some toffee or some chocolate from his father, and mother is getting angry on her child. Okay, so this is like analogy of alloimmune thrombocytopenia. The baby is harboring Okay, baby is harboring the paternal antigen and mother maternal antibody are acting against it. Okay, so this is actually mother's antibody against baby's paternally inherited platelet antigen. So just remember in a story form. Okay, so this is basis of this. So platelet antigen from this theory, this story also itself. Just remember, platelet antigen presents on fetal platelets only. So they are present on fetal platelet only. Okay, antigen type you have to remember, generally it is hp1a, this is 75%, but in Asian population hpa4 is common. Still if they ask which antigen is common, you have to answer hpa1a. It is seen in 75% of population, but they specifically ask Asian population, you can answer HPA4 also. Platelet count is generally less than 20,000 in this condition. Okay. Timing of thrombocytopenia. Thrombocytopenia generally starts at birth. Sorry. If you do maternal examination, maternal platelet count are normal because maternal antibodies are against only paternal antigens on the baby. Okay, not maternal antigen itself. So normal platelet count will be there. So this is important differentiating factor in this condition. Intracranial hemorrhage seen in 10 to 15% of patient. Antenatal management you have to do, you can give maternal IVIG steroid. There are separate guidelines for that. Baby treatment, you have to actually treat baby with IVIG methylpred. So net treatment guidelines is, I have concised them in a simplified manner. If your platelet count is less than 25,000 and baby is term, if platelet counts are less than 50,000 and the newborn is preterm, or platelet counts are less than 1 lakh plus intracranial hemorrhage is there, in this condition of aluminum thrombocytopenia, just transfuse RDP. Okay, but platelets are less than 50,000 in asymptomatic neonate, your drug of choice will be IVIG. But if your neonate is resistant of both IVIG and RDP, methylprednisolone is second drug of choice. Okay, so I have discussed neonatal alloimmune thrombocytopenia in slide story format, and all points are potential question. Okay, you have to remember all points because this actually is favorite topic of AIIMS examiners. Next, in contrast, we'll compare autoimmune thrombocytopenia. In this, what happened? Mother actually produced antibody against baby antigen and mother antigen both. Okay, so here no paternal influence is there. Baby antigen, mother antigen both actually are facing similar problem. Mother is producing antibody against these two antigen. Okay, so in this condition, maternally derived antiplatelet antibodies. So antigen is where we have discussed it just now. Platelets on both maternal and fetal platelets. Okay, what is antigen type? This is GP second B third A or GP 1B 9 complex. We have to remember these two. Okay, these are two antigen targets. Likewise, HPA in alloimmune thrombocytopenia. Platelet count are generally more than 50,000. Timing, it can be birth, it can be near normal at birth and then fall. Low platelets seen in mother, it is very important, but one question was previously asked, if mother is having splenectomy, low platelets will not be found even in autoimmune thrombocytopenia, so you have to be wise enough. History of ITP SLE in hypothyroidism. Okay, so this can be your potential next exam question. Scenario can be given, a history of ITP SLE hypothyroidism is there. Okay, so it can point towards autoimmune thrombocytopenia. The treatment is almost similar, IVIG, methylprednisolone. Some guidelines are there, like less than 30,000 of platelet count give IVIG plus RDP, and if it is more than 30,000 of platelets, give IVIG. So just pause this video, revise this autoimmune thrombocytopenia once and for all in story format or whatever format you want to remember this, but this is ultra important. Okay, so going forward to next, hemoglobin. So hemoglobin in cord blood. So in hemoglobin cord blood, embryonic hemoglobin is not found in cord blood, but generally you have to see what is the embryonic hemoglobin. Go over 1, go over 2, Portland, and you have to remember these zeta 2, epsilon 2, alpha 2, epsilon 2, zeta 2, and gamma 2. These you have to remember. Okay, so what I remember them in my mnemonics, JAG, EEG. Okay, so this is my mnemonics. You can remember by any mnemonics. Gover 1, Gover 2, and Portland. In like globin polypeptides, you have to remember if all. Fetal hemoglobin, BART hemoglobin is found in cord blood. Gamma 4, that is less than 1%. Hemoglobin F, it is alpha 2, gamma 2, 60 to 85% is found. Adult hemoglobin, just remember HbA is seen in 15 to 40% and HbA2 is seen in less than 1%. So this hemoglobin composition of cord blood is very much important. Going forward, hemoglobin nadir is seen where? Okay, so hemoglobin level in healthy term infant, if you see at 10 to 12 week, hemoglobin is as low as 10 gram per deciliter. You have very important, very low birth weight VLBW infants 1 to 1.5 kg, that is at the 4 to 6 week the hemoglobin is as low as 8 gram per deciliter. Extremely low birth weight babies less than 1 kg, hemoglobin at 4 to 6 week, hemoglobin is as low as 7 gram per deciliter. So we have to remember these fact based hemoglobin value of hemoglobin nadir. Okay, so how you will approach to anemia? So this is simplified actually flow chart. Hope you all are well versed with it. Hemoglobin concentration is decreased. Just see reticulocyte count. If they are low, something is not producing hematopoietic cells. Three DDs are there: congenital hypoplastic anemia, congenital infections, and congenital leukemia. Okay, but retics are normal or high. Just do Coombs test. If Coombs test is positive, so think of immune hemolytic anemia, ABO, RH in minor blood group incompatibility. But your Coombs test is negative, then go for MCV. If MCV is low, it is chronic intrauterine blood loss or alpha thalassemia syndrome. But MCV is normal or high, just see peripheral smear, and you have to many things in peripheral smear, we'll discuss them later. This is actually not the classical description, basically this practical approach how to will approach anemia in newborn. Okay, microspherocytosis seen in two condition. This is previous NEET SS question. ABO hemolytic disease and hereditary spherocytosis, we'll discuss them later. As of now, just remember this. Okay, so morphological abnormalities in erythrocyte in neonate with jaundice. Okay, so this is pathology thing, but we'll discuss here as a neonatologist. We need to know this. So as I discussed just now, microspherocytosis is seen in two conditions: hereditary spherocytosis and ABO hemolytic disease. So just remember previous year question also, MCHC and MCV are elevated in hereditary spherocytosis more than 36, very much important, or 0.36 you can say. And in this ABO hemolytic disease, they are normal. Okay. So again, bite and blister cells are seen in G6PD deficiency, echinocytes are seen in PK deficiency, cystocytes are seen in DIC, Henge body, ADMTS13 deficiency, neonatal HUS, and giant hemangioma. So they can ask cystocytes are seen all except. Okay, so they can put any combination question, just remember this. Okay. Uh, okay, many syndromes are there which are associated with congenital hypo regenerative anemia. I have discussed them in detail in my hematology NEET SS video. You can go there. Inherited bone marrow failure syndrome topic name is there. You can go go in detail. I'll just discuss what are the syndromes like dyskeratosis congenita. I have discussed there. Diamond Blackfan syndrome. I have discussed in detail. AD deficiency. Other syndrome like osseous hemorrhagic telangiectasia syndrome. This leads to hemorrhagic anemia. Peutz-Jeghers syndrome, iron deficiency anemia. ATRX and ATR16 syndrome, that is hypochromic microcytic anemia. Okay, going forward, your neonate is having jaundice and you have to actually approach them. So just do DCT. Okay, if your DCT is positive, just if your DCT is positive, just see ABO hemolytic disease can be your answer. But if your DCT is negative, just do, we have discussed just now, if MCB is more than 0.36, it can be hereditary spherocytosis. Plain CBC can give you answer. Okay, that's why this is examiner's favorite question. If that is DCT is negative, you have to see other intrinsic defect like G6PD and pyruvate kinase deficiency. Obviously, if your diagnosis is not clear, you have to go complex algorithm of neonatal jaundice. We have discussed it earlier in earlier videos also, but you have to just it is DCT based approach you have to see. Okay, so there are transfusion thresholds which are very important. In absence in respiratory support or in absence of respiratory supports, what are the hemoglobin concentration in which we have to transfuse the baby? Okay, in first week transfuse at 11, in week 2 10, and week 3 it is 8.5 in presence of respiratory support. But if no respiratory support is there, you have to transfuse at 10 8.57, approximately 1.5 gram per deciliter lesser than original value. Okay, so just pause this video and remember this anyhow, these value, because these are important for exam and practical along with your practice also. Okay, going forward, so, hemolytic disease etiology. This is a very important table because this having lot of concepts, and AIIMS examiners or INA examiners loves concepts. Okay, so RH antigen ABO. Just I'm just pay attention where I'm actually want your attention. In ABO incompatibility, generally mother blood group is O, but it can be B also. You may be surprised to know this. It can be B also. An infant most common blood group is A. Sometime it can be B. Just remember this. Okay, very much important. Okay, RD positive. D is most common, and many RD antigens are there, but D is more common in RH. Firstborn, in firstborn, ABO incompatibility is in full swing, 40 to 50%. But in firstborn, RH is less, around 5%. It is seen very much. So, severity in subsequent pregnancy. In RH, it is predictable that it will increase, but in ABO, it is difficult to predict. Very much important. Okay, jaundice. Jaundice is prominent and severe, mild in ABO incompatibility, along with anemia, which is frequent in RH incompatibility. If you will do DCT, it will be always positive in RH incompatibility, but it may be positive or negative in ABO incompatibility. Very much important differentiating factor. Okay, RBC antibodies on mother. Uh, Previous year INI question, antibody titer may help predict severity of fetal disease. So RH antibodies actually help predict severity of fetal disease, again very important. And ABO incompatibility, it is not so. Cal antigen, K1 is negative, K1 positive. Okay, we have to remember basically just RH and ABO differentiating factor you must know. Going forward to a very common condition, vitamin K deficiency bleeding syndrome. It has been divided like early onset disease 0 to 24 hours, classical vitamin K bleeding disease 2 to 7 days, and late onset disease, that is 1 to 6 months. You have to remember just causes maternal drugs or like any vitamin K inherited coagulopathy in maternal drugs are generally implicated in early onset disease. What you have to do, you have to give antenatal vitamin K to mother, that is 20 mg. Obviously you have to give to baby also, but mother you have to give in 20 mg in high risk mothers. Okay, classical disease that occurs in 2 to 7 days. Vitamin K deficiency in exclusive breastfeeding, if baby is there, deficiency can be there. Prevention obviously from vitamin K at birth, and generally the high risk factors you have to see. Late onset vitamin K deficiency disease appears at 1 to 6 months. It leading to cholestasis, A beta lipoproteinemia, idiopathic disease, warfarin ingestion, and cholestasis. Okay, so hope you are with me till now. Okay, if you are with me till now, you will get benefited a lot from this discussion, because this is actually a very concentrated discussion of neonatal hematology and actually pediatric hematology boundaries I'm crossing because it is intermingled. Okay, so this is your hematology part of other pediatric hematology will be somewhat is covering in this part. So stay actually active, alert, don't sleep in between. Okay, polycythemia will discuss. So polycythemia definition you have to remember: venous hematocrit is more than 65. They will say arterial hematocrit and all, but definition is venous hematocrit, or it is not and. Just remember, venous hemoglobin is more than 22, either of one, like either one venous hematocrit is more than 65 or venous hemoglobin is more than 22 gram per deciliter. Okay, you have to see a normal hematocrit. What is normal hematocrit in newborn? At 2 hours of age, hematocrit peaks in newborn. It reaches up to 71%. Very much important. Why this happened? Due to transduction of fluid out of intravascular space. The region is clear. At 6 hours, it falls at 68%, but it stabilizes by 12 to 24 hours. This is how normal hematocrit varies. Okay, hyperviscosity definition, this was asked in AIIMS exam or IN exam twice. What is the definition of hyperviscosity? Viscosity is more than 14.6 centipoise, or at the shear rate of 11.5 per second. This is important. Okay, etiology of polycythemia, just see, this is common sense also. Intrauterine hypoxia leading to polycythemia, maternal diabetes, neonatal hyperthyroidism, congenital adrenal hyperplasia, chromosomal abnormalities, Beckwith-Wiedemann syndrome, delayed cold clamping, and maternal fetal transfusion. So these conditions are important for neonatal polycythemia. They can ask all except question from this. Okay, I am going very fast because I have to cover this all in a short period of time, which is not possible without going fast, because we are doing a revision fast track. The name of revision is itself fast track. Okay, so screening of polycythemia, in which condition we will do? Obviously, the risk factor we will do screening: SGA, IDM, LGA, twins, larger twins, IUGR. You have to do this. What should be your schedule for screening of polycythemia? At 2 hours, if it is high, repeat at 6, 12, 24 and 48 hours. But just remember, age of cutoff value we have just discussed: 2 hours, 6 hours, and after 12 to 14 hours. Okay, so this is simplified approach of this polycythemia. If venous hematocrit is 65%, okay, this you have labeled that neonate as polycythemic. Exclude dehydration and check weight loss. Okay, just hydrate the baby. Okay, if the hematocrit 65 and baby is symptomatic, is there, So you have to just partial exchange transfusion, no confusion, but your baby is asymptomatic. And if hematocrit is more than 75%, you have to do partial exchange transfusion. So in nutshell, partial exchange transfusion criteria are hematocrit more than 65% plus asymptomatic, and hematocrit at more than 75% with asymptomatic newborn. You have to do partial exchange transfusion. If your hematocrit is between 70 to 75, consider hydration. Between 65 to 70, monitor for symptoms. Okay, so this actually partial exchange transfusion, it was a recent actually NEET SS 25 question we have discussed in our discussion also. So what will be the formula? Formula will be simple: blood volume into observed hematocrit minus desired hematocrit upon observed hematocrit. Okay, so just solve this formula. Just remember important thing which is heck also. A rule of thumb is volume of blood to be exchanged is usually 20 ml per kg. After having this formula, this is rough formula. Okay, so you have to remember this formula. Okay, blood component selection, actually this is core hematopic, but just remember, if you are giving PRBC, it should be compatible. If you are giving RH isoimmunization, RH negative blood of baby ABO type, compatible with maternal plasma. ABO incompatibility, actually in this condition also similar. Okay, I'll explain them later. Platelets count should be AHP compatible in NEIT NET, and avoid group O platelet with non-O group patients. FFP and cryoprecipitate should be ABO incompatible. So this is stable. You have to remember this, and actually there is lot of concept behind this as of now. If your neonate is O, okay, your choice of uh, ABO group for transfusion, first choice in RBC obviously O will be there. Second choice, you can't give any blood group to O positive patient or O blood group. Platelet you can give AB, A or B. Similarly, FFP you can give AB, A or B. A blood group, obviously first choice will be A, second choice will be O, AB and AB for RBC, platelet and FFP. B, O, AB and AB, and AB, O, A, B and plasma free of A and B in platelets. So you have to remember these choice of ABO blood group. Okay, this is actually important to understand concept behind this. If you are not short of time, just remember this chart, because I think one or two questions are expected out of this. Okay, uh, PRBC transfusion threshold in sperm neonate, we have discussed it also. Okay, so this is a refined version of that. If severe pulmonary disease is there, moderate pulmonary disease there, severe cardiac disease, major surgery, symptomatic anemia, they'll ask straightforward question in this. If severe pulmonary disease is there in term unit, less than 10 is there actually, so you have to transfuse. Moderate pulmonary disease less than 8, in severe less than 10, in moderate less than 8, severe less than 10, major cardiac severe cardiac disease less than 10, major surgery is less than 10, and symptomatic anemia less than 7. So once they ask what is the definition of symptomatic anemia, just remember these all parameters, like 24 hours tachycardia, heart rate is more than 180, RR 60. Okay, doubling oxygen requirement in 2 days, serum lactate is more than 2.5, or pH is less than 7.2, weight gain is less than 10 gram per kg per day, or previous 4 days receiving more than 120 kilocalorie per gram per day. This is called symptomatic anemia. So you have to remember these threshold in term units. Straightforward question can be asked from this. Okay, indication of FFP and cryoprecipitates. Okay, first I'll go with cryoprecipitate. Factor 8 deficiency, factor 13 deficiency, afibrinogenemia, dysfibrinogenemia, and wall Willebrand factor disease if DAP and factor 8 concentrate are not available. In these conditions, you have to transfuse cryoprecipitate. Okay. So FFP, transfusion, DIC, VKDB, bleeding and significant coagulopathy, you have to transfuse them. This is actually neonatal thrombosis drugs doses. Like heparin dose, you have to remember 75 to 100 units per kg, followed by infusion. Low molecular weight heparin like enoxaparin 1.5 milligram per kg twice daily, you have to remember. Vitamin K antagonist, you have to remember, start like warfarin and dabigatran, which is actually a new drug. Okay. And breast milk has low vitamin K concentration, best for infants sensitive to effect of vitamin K antagonist. Okay, so this is a tissue plasminogen activator, which is 0.1 to 0.6 kilogram per milligram per kg per hour. So you have to remember this. UFH should be titrated with anti-factor 10A or APTT. This is common sense. And target anti-10A is 0.35 to 0.7 units per ml. So this is also important. Contraindication of anticoagulation thrombolysis is also important. This is core hematology question, but it is applied to neonates also. Absolute contraindication of thrombolysis seen as surgery. Okay, or ischemia, birth asphyxia within 10 days. You can't actually use this. Active bleeding, invasive procedures within 3 days, and seizure within 48 hours. You have to be well versed with timelines of 10 days, 3 days, and 48 hours. Okay, relative contraindication, platelet counts are less than 50,000. Fibrinogen concentration is less than 100 milligram per deciliter. INR if it is more than 2, and seizures are if severe coagulation deficiency, hypertension. Okay. We are just finishing up this neonatal hematology. I understand this is going actually very concentrated, but just with me for a few times. Okay, so central venous thrombosis. In this condition, management is, if without ICH, use LMWH and UFFH followed by low molecular weight heparin. If ICH is there, either use anticoagulation or supportive management with radiological monitoring. So basically, this question can be asked like in format of any case scenario. Neonatal stroke, how you will manage? Okay, first arterial ischemic stroke is there with no ongoing embolic source. Do supportive care. But first arterial ischemic stroke with documented embolic source, start with UFH or low molecular weight heparin. Recurrent, agar AIS is there, UFH or aspirin can be used. So this is neonatal stroke actually treatment can be asked. Renal vein thrombosis, if it is this is PYQ. If unilateral renal vein thrombosis with IVC extension is there, treat with UFH or low molecular weight heparin. If bilateral RVT with renal impairment is there, treat with same UFH and LMWH or initial thrombolysis followed by ultrafractionated heparin. Okay. Similarly, femoral artery thrombosis, central catheter thrombosis, peripheral catheter thrombosis, and neonatal purpura fulminans. We have to actually just go through this slide once again. Nothing to explain in this slide. You have just remember how you will prevent this. It is important. In this condition, Haploc injection is there. Uh, which contains approximately 10 units per ml of heparin. In PIC line, 0.5 to 1 units per ml of ultra-fractionated heparin at 1 ml per hour you can give. In umbilical catheter, this dose should be 0.5 to 1 units per ml. So this is how you can prevent this thrombosis. Neonatal thrombocytopenia, last topic of today. I just draw your attention to congenital neutropenias, which is you have to remember name of those: Costman syndrome, reticular dysgenesis, Costman syndrome, reticular dysgenesis, Barth syndrome, Schwann-Diamond syndrome, cartilage hair hypoplasia, and cyclic neutropenia. These two are very much important. Okay, so Costman reticular dysgenesis, Bath syndrome, and Schwann-Diamond syndrome. So this was it for neonatal hematology. Just revise this neonatal hematology once again, and you'll be actually for any questions for neonatal hematology. I don't think so. Any question will be actually far away from our discussion. It can be solved from these concepts itself. So we'll be continuing this amazing series of INSS Neonatology Fast Track Revision. We'll discuss another system or topic of neonatology in next video. Till then, keep reading and do share, like, and subscribe our channel. We'll meet in another video.